Um, First of all, we would like to thank Pfizer to allow us to present our study. I'm not going to talk about tafasitamab studies, but I'm going to talk about King Fahd Medical City study in tafasitamab rheumatoid arthritis, real world in Saudi Arabia. So now this is our study, and as you know, tafasitamab is a selective JAK inhibitors that blocks both JAK1 and 3. And tafasitamab has an approximately 3 hours half-life, 70% excreted by liver, and it has been approved for treatment of rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and ulcerative colitis. And why we did this study, as you all know, in the beginning of 2022, there was a study which called Oral Surveillance, has been published, and that paper indicates that tafasitamab might be associated with increased risk factor of cardiovascular adverse event. But when we look deep in that papers, we found the population of that papers are those who are at high risk for cardiovascular disease, such as elderly above 60, and those who have previous coronary artery disease, and so on. And then it comes in our mind, what's about the Saudi population? When we look to the literature, there was nothing indicating or evaluating tafasitamab's safety. I'm not talking here about efficacy, because as you all know, efficacy is better to be determined by RCT, but the safety is better to be determined by real world data, where you don't have you don't have specific exclusion and inclusion criteria. So as you all know, now EMA confirmed measures that to minimize the serious side effect with JAK inhibitors in general, they say this is not specific for tafasitamab, it's probably related to the group side effects. And they indicated the people who are at high risk for cardiovascular should avoid JAK inhibitors. And that's what I'm still encouraging all of you. Those who are at high risk for cardiovascular events and thrombosis, we should think several times before we start JAK inhibitors. So this is our paper. And now we saying that what's about our Saudi population? Are we different? Are we similar? Do we have to pay more attention when we are going to use tafasitamab in treating our rheumatology patients? And to be clear, all the patients are rheumatoid arthritis. At that time, we don't have experience in axial in general spondyloarthropathy. So we include all patients with rheumatoid arthritis. And one of the beauty of real-world data that it does not exclude elderly. We include everyone who is adult, aged 18 to 80 years old. Anyone seen once after the inclusion of tafasitamab as a formulary drug in King Fahd Medical City from 2016 up to that data 2022. And we are giving our patient 5 milligram twice daily. So we look to the record of our patient retrospectively, and we included 100 patients. And to tell you, this is the largest Saudi cohort published tafasitamab data so far. And we excluded younger than 18 because at that time we don't have data about pediatric, and you know internationally the adult age is considered at age of 18. And of course, any pregnant was excluded. We look to the data at the beginning, 3 months, particularly when we start to use tafasitamab. It was new to us, so we were following our patient closely, and then 6 months, and after that, every 6 months, up to 24 months. We look, the concern was the safety. Again and again, this is a real-world data, and the concern is about the safety. We look to the thrombotic events, we look to the herpes zoster, and we look to the alteration in the liver function, as well as the WBC's hemoglobin, platelet, lipid profile, and inflammatory markers. This is the demographics of our patient. And interestingly, that majority of our patients, 85, are female, and that's also matching the international cohorts. And if you look here, most of our patients were less than 10 years, and I think this is a huge advancement in the picking up or diagnosing rheumatoid arthritis in our country. We wish to short it as much as we could, but now we have many patients diagnosed or at least evaluated by rheumatologists in less than 10 years. Again, real world data, why I like it? Because it includes everything. If you look here, 12% of our patients dyslipidemic who are at high risk. It's considered one of the risk factors for coronary artery disease. Diabetes, as you all know, the latest prevalence of diabetes around 24 to 25% in Saudi population. 23 of RA cohort is having diabetes. 18% is having hypertension and so on. And we have patients who have previous heart failure. 4% of our patients have been diagnosed with heart failure. And then we look to the discontinuation. I think this is extremely important when we talk about JAK inhibitor, and now here specifically I'm talking about tafasitamab. And we look to the discontinuation, 33%, which means 33 patients discontinued tafasitamab over the period of study, which is 2 years. And then we have to look why was discontinued. Was it due to the side effect or due to the lack of efficacy? And very reassuring that the discontinuation was not related to the side effect. As you see here, 12 patients out of 33 discontinued the medication because of active disease. And 7 patients discontinued the medication because of the patient's request. And unfortunately, we don't know why, because this is retrospective. But again, for me, this is very reassuring because we have only 1 patient who developed stroke, only 1 patient who developed TB, and 2 patients developed leukopenia, and 5 patients, they have high liver enzyme that mandate discontinuation of tafasitamab. And I think this result very reassuring about the safety of tafasitamab and JAK in our population. So the majority of discontinuation was either due to the disease activity or patient's request. We don't know what is it exactly, and this is, one of the limitations of retrospective study. There was no serious adverse event was noted among our patients, as I said, except 1 who had stroke. None, again and again, none of our patients developed DVT, PE, MI, coronary artery disease, or malignancy. However, malignancy, it's over only 22 years, 24 months. We have to keep more eye. But again, this is very assuring when we talk about the safety of the JAK inhibitors, particularly tafasitamab in our Saudi patients. This is a busy schedule just to show you that there was no significant differences in the hematological parameters in the patients who were given tafasitamab, including LFTs and inflammatory markers. Now, let us go deep. When we look to the AST, as you see, sometimes it goes up and down, but in general, it's within the normal range. Similar to the ALT. So there was no, this is, of course, the mean of the ALT and AST. So there was no significant signals toward the abnormal liver function test. Lipid, which is, again, it's a major concern when we start tafasitamab or JAK inhibitors. And as you see, LDL was ranging between 3 to 3.5. And we all know from tafasitamab trials that if you start statin, the patient would respond very well to the lipid abnormalities. Platelet, there was no change. Hemoglobin, because you all know now the JAK inhibitor behave like IL-6 to make it simple for the junior fellows and resident. JAK inhibitors, again, downstream block IL-6. So you should deal with JAK inhibitor as IL-6 inhibitors. So in a patient with significant anemia, patient with significant leukopenia, you should avoid this agents. And those who developed low hemoglobin or WBCs, it looks to how further low these abnormal cells, and then you need to interfere. However, when we look to our patient, none of them developed significant anemia or significant drop in the WBCs. So, in conclusion of the largest study in Saudi Arabia about the tofacitinib real-world data in RA, there was no significant thrombotic events. Only one patient had herpes zoster infection, despite none of our cohort at that time received Shingrix, and nowadays it's available. We started in our hospital to prescribe it. Even from rheumatology, they could prescribe it. It's not restricted to ID anymore. There was no significant lab abnormalities, and we have an excellent safety profile so far with tofacitinib. So, thank you very much.